So we've heard basic things that we all should know on cartilage repair, and I'll add a little bit of our experience and investigation that we performed together with the University of Leuven in the research of this cartilage repair using ChondroCelect. Okay, what is ChondroCelect? Well, ChondroCelect is a medicinal product that is available, and it's based on characterized chondrocytes. These characterized cartilage cells are expanded in ex vivo, of course, and they express specific marker proteins. The thing is, when you use this technique, that you remove cells from the body and then you put them in culture, but you check the viability of these cells so that in fact what you reimplant are the best cells that perform best in the lab. So you know that you have the best cells and not just the whole number of cells of this individual that you reimplant, and you request this to have better results starting from these cells. It is indicated for symptomatic cartilaginous defects, and we are discussing here grade 3 and grade 4. And in the clinics, we've also treated patients additionally with concomitant asymptomatic cartilage defects, grade 1 and grade 2, as you know, which happens in the clinic, and you see the illustration here. The identification of these patients is, as we mentioned, single symptomatic cartilage defects. That's how we choose in the randomized controlled trial on the femoral condyle, grade 3 and 4, and lesions up to a maximum of 15 centimeters. You know, the usual lesion is 3 to 4 centimeters, and we're happy with that, but you can approach lesions that are bigger, up to 15 centimeters, and we know, and Professor Cohen has just stated that very clearly, you better use an Oates one single block, but that goes up to 10 millimeters, and in fact the larger lesions are limited because of this approach and technique. So the process overview is illustrated here. It's really very classical. You remove the cells, you put them in culture, you test them, and then of course you rehabilitate them. And Bill Rodke has stressed also very much the recovery and the rehabilitation, which you see on the right-hand side of the lesion. And very often this is not followed up to the rules and may enhance or diminish the results progressively. It's based on the Brit-Beg technique, which you know. You remove the cells and you put them in practice, in culture, and then you put them back. But you can also not only use the periosteum, which you know is very tricky, it's not always very easy to use. It takes more time during surgery, and therefore you can also use a seeding technique with a membrane with the cells on it, or the membrane, a synthetic membrane without the cells. And then you can use sutures, or you can use something that sticks without the sutures, because the sutures are really a tedious job to perform, especially when we used in the RCT. The periosteum is really time consuming, and you probably can improve the results by doing it faster with preceded membranes without the suture. Now let me discuss with you this randomized trial that was performed a number of years ago, and also including compassionate use program and the results of the post-authorization registry. When you look at the RCT, which we performed originally, we compared our technique with ChondroCelect versus microfracture according to the rules as it's been described by Bill Rodke earlier this morning, and we've seen at 1 year at biopsies the overall histology assessment to be proved better using the ChondroCelect implantation, and also investigated the histomorphometry, which seemed to be, according to this investigation, to be better than the microfracture approach. And this, I think, is a very important slide in my presentation. When we look at the clinical results using the Koos scores, there are two different set of results. On the left-hand side, you see the lesions that have been treated when the onset was less than 3 years before we used the ChondroCelect or the microfracture. And on the right-hand side, you see a group of patients that had chronic lesions more than 3 years after the onset of the symptoms. And it is obvious that when you address younger symptoms, less than 3 years, then you see clearly that the ChondroCelect procedure gives better Koos results, overall Koos results, than if you address patients that have been complaining with symptoms of this cartilage lesion longer than 3 years. And that is a message that came out of this particular investigation. We looked more specifically in Belgium and the Netherlands, and you see the enrollment status that was up to last year. And you see the different pooled database, patients entered in the city with baseline with Koos and a baseline before and Koos after. And you see that the distribution of the size is indeed around 3, 4, 5, and 6 centimeters. The usual characteristics of this type of lesion that you recognize in day-to-day practice. It's very rare to have more extended lesions that are encountered and where the results are more difficult to obtain. From this registry, you see on the right-hand side that the Koos 4 score evaluation in the RCT, again, in symptoms that are less than 3 years, and this is a follow-up of 5 years, indeed the results progress much better with the ChondroCelect patient's implantation versus the microfracture, even though the microfracture runs satisfactory as well, as you see. When you look at the results from the registry, this comes with the same results also in patients with lesions onset less than 3 years. And we further investigated the Koos subdomains, and you see in these patients, as you look at the baseline, things are going very well, but regaining sports activities are relatively limited and do not reach the really value of activities of daily life. So when you approach sportsmen, of sports women, this may be a limitation at 5 years, not at 5 years, here at 2 years, when you address these type of lesions, looking more specifically in Koos sports. Gender does not really influence, and when you look at the sizes using this technique, remember it's from 3, 4, 5 up to 6 centimeters, very rarely more extended lesions. This does not apparently influence the clinical results at 2 years. When you look at the Koos and the patients with baseline in the younger age, you see that this functions quite well. Again, the sports activities are relatively limited or not as high as results as you may expect. When you move on to patients that are older than 50 years of age, the curve is a little bit more static and reflects appropriate results. Of course, when we did the RCT and when you use the registry, this Digenics approach, this ChondroCelect approach, implanting cells, is an open surgery. It's not like microfracture, where this is an arthroscopic surgery, and you see that cartilage hypertrophy is, as one can expect, a little bit higher in number. Also joint crepitation and swelling. These factors are probably due to the open surgery when you compare this to the arthroscopic approach, which was the baseline comparable method that we used in this investigation. I think using these cells, we know what we implant. We take the best cells from the patients and return them to the pathological location, which a limited size, in some cases is also indicated up to more than 10 square centimeter, but you need really a clear patient identification to obtain these results. We've seen that they give durable results at 5 years and more. And what is also important is that the chronicity, the early treatment matters, and this is something that came out of this investigation that we did not really expect to come as clear. Early treatment matters, which means that probably in all approaches in cartilage surgery, we probably should be a little bit more aggressive and not wait until things stand out and probably the subchondral bone is not functioning very well to take up to normal function. And of course, this is quite flexible and easy to use. So thank you very much for your attention.